And the second speaker will be Professor Mancia. We are very happy to have Professor Mancia with us, and he will speak about a very important issue we are facing in everyday practice. That's when to start antihypertensive therapy. It looks an easy question, but I think it's very important.
Ladies and gentlemen, distinguished colleagues, my name is Gusseppe Mancia. I am Emeritus Professor of Medicine at the University of Milano Bicocca. I'm very grateful for this invitation to discuss a major issue in guidelines, that is, when to start antihypertensive drug treatment, at which blood pressure levels. Now, the guidelines of the European Society of Hypertension, which were published about a year and a half ago, are quite clear about this important issue. 3 points are emphasized. First of all, office blood pressure remains the reference blood pressure to look at because hypertension-related risk benefits of antihypertensive treatment and treatment-related blood pressure threshold and targets are all based on data collected via office blood pressure. Out-of-office blood pressure is important, it can be helpful, but it should not be regarded as the reference blood pressure value because no trials are available with out-of-office blood pressure. Which is the level of office blood pressure at which to start giving antihypertensive drugs to our patient. Now, the guidelines of the European Society of Hypertension, they rely on a principle. That is, hypertension and the drug treatment threshold should be the blood pressure level at which or above the benefits of intervention exceed those of inaction. Or intervention does more good than harm. And this is a very famous sentence expressed by Professor Geoffrey Rose in 1971, a famous British epidemiologist. What does this mean in practical terms? Well, it means that the blood pressure level at which to start antihypertensive drug treatment should be the entry blood pressure level in trials which have shown the protective effect of blood pressure reduction. And these are, in many, many instances, a systolic blood pressure equal or above 140 millimeter mercury and or a diastolic blood pressure equal or above 90 millimeter mercury. And this is one of the algorithms of the guidelines, and it very simply shows that at the blood pressure value of 140 millimeter mercury systolic or above, or 90 millimeter mercury diastolic or above, drug treatment should be employed, together, of course, with lifestyle intervention. And this is the case, of course, for all levels above 140 over 90 millimeter mercury, including very high blood pressure levels. Now you can see here what is a small exception to this rule. That is, if patients have a very modest increase in blood pressure above 140 millimeter mercury or 90 millimeter mercury, say 144 millimeter mercury systolic, and a minimal increase in cardiovascular risk, then doctors can try to control blood pressure only through non-pharmacological interventions. But there is a time limit to this. If within 3 months blood pressure is not controlled, which is obtained also via good adherence of patient to non-pharmacological intervention, then drug treatment should be started also in this special case. This is a meta-analysis of randomized trials, which has been published a few years ago. And it shows what happens in patients at a very high cardiovascular risk. That is, patients who had a previous cardiovascular event. And you can see that in this condition, blood pressure reduction can be protective. And in this case, the initial blood pressure in these patients was 130, 139 millimeter of mercury range systolic, or 85, 89 millimeter of mercury diastolic. That is, it was in the so-called high normal blood pressure range. So you can see that in patients at very high risk, well, if treatment starts at lower blood pressure value than 140 over 90 millimeter of mercury, there can be protection. And this leads me to the very clear and simple conclusion of the guidelines on this issue. In primary prevention, the threshold for drug treatment should be values of blood pressure equal or above 140 or 90 millimeter of mercury. In secondary prevention, the threshold is somewhat lower. That is a threshold which includes high normal blood pressure values. And because data originate from randomized clinical trials, these two recommendations are given the maximal level of strength. But of course, it's non-biological to think that one blood pressure threshold fits all highly heterogeneous hypertensive patients. And here I put some questions. First of all, the first point is not a question. That is, the threshold of 140 over 90 millimeter of mercury office blood pressure is valid also for older patients. That is, patients aged 65 to 79 years. And indeed, the greatest portion of the evidence we have on the protective effect of antihypertensive treatment comes from studies which have included patients within this age range. But what can we say about the blood pressure threshold in patients in this age range, but with isolated systolic hypertension, high systolic blood pressure, and normal or low diastolic blood pressure? What can we say about patients very old, that is, age 80 years or beyond? And what can we say about blood pressure threshold for drug treatment in frail patients? Well, this is the evidence from randomized trials available in patients with isolated systolic hypertension. You can see that in this meta-analysis of 5 randomized outcome-based clinical trials for a total of about 16,000 patients, reducing blood pressure was associated with the clear cardiovascular protection. But please notice that the initial blood pressure values in these patients was more than 170 millimeter of mercury. And in all these trials, the entry blood pressure criterion was to have a systolic blood pressure equal or above 160 millimeters of mercury. So well above 140 over 90 millimeter of mercury threshold. And this is the case for people older than 80 years. Only one trial is available, a randomized clinical trial, very well known to all of you, is the HIVET trial. And in HIVET, as you remember, reducing blood pressure was accompanied by very clear reduction in stroke, and even more marked reduction in heart failure, and also significant reduction in all-cause mortality. But once again, please look that the entry, these patients had the blood pressure above 170 millimeter of mercury. And once again, the entry criterion was to only recruit patients with a systolic blood pressure equal above 160 millimeter of mercury. So even in this case, the evidence of beneficial effect of antihypertensive treatment is restricted to patients with a very high initial blood pressure. This led the guidelines of the European Society of Hypertension to reach the following conclusion. I already mentioned that in patient age 65 to 79 years, the threshold is 140 over 90 millimeter of mercury, like the threshold in the general hypertensive population. In patients with isolated systolic hypertension, the first threshold is 160 millimeter of mercury, and this is the strongest threshold because of its origin from randomized outcome-based trials. But then the guidelines consider also some other types of evidence, necessarily weaker. That is, that in patients with isolated systolic hypertension, physicians may also consider a blood pressure range for treatment initiation of 140 over 150 and 140, 159 millimeter of mercury. And this is true also in patients aged more than 80 years. Please notice that the level of evidence for this second recommendation is weaker than the level of evidence for the first recommendation. How about frail old patients? This is a painful issue for antihypertensive treatment because unfortunately frail patients are not recruited in trials. In general, vulnerable patients are not recruited in trials, and this is the reason why the evidence is so poor. But some evidence is available that even in frail patients, antihypertensive treatment may be protective. And I would like you to show you a study which was published not so long ago, and it comes from the database of the Lombardy region, which is the region where I live, 10 million people, and we have access to this database. And what was done was based on a score which was constructed through data from more than 20 million patients in various regions of Italy. We divided our population into 4 groups, and the fourth group had a very clear increase in the risk of dying over a few years, more than 60% mortality over 5 to 6 years. And this we call frail patients based on this predictive score. And then what we did was to look at the adherence of all these 4 groups to antihypertensive treatment, which could identify in the database. And I would like you to notice that the greater was adherence to treatment, from less than 25% of the follow-up time to more than 75% of the follow-up time, was associated with the progressive reduction in the incidence of all-cause, in the risk of all-cause death. And this included also the 4th group I mentioned before, that is the group with the very high mortality. Patients who were very adherent to treatment, they had a significant reduction in the risk of cardiovascular events. So this suggests, and I use the word suggest because this is not a trial, but comes out of observational data. Well, it suggests that even in frail patients, antihypertensive treatment can reduce the risk of dying. Now, these data do not tell us anything, however, on which should be the threshold for treatment or the target for treatment. But the guidelines try to help physicians by inviting them to make use of a score which quantifies the independent of the patient's life from outside help. It's called the CATS score, and it is based on a score from 6 points to 0 points. If patients are found to be fit under these conditions, then treatment should be the same as the one I mentioned before. But if patients are found to be severely dependent, dementia, chronic bedridden, or other conditions which deprive them from an independent life, then of course the priority goes to other condition than hypertension, and antihypertensive treatment can be used, but in a very conservative fashion. This can be helpful, but please remember that this is based on clinical considerations and not on antihypertensive treatment trials. Now, let me remind you that I've talked about the threshold for treatment and drug treatment. When we limit our perspective to non-pharmacological treatment, then there is no threshold to non-pharmacological treatment. At any blood pressure, if lifestyle is not correct, then non-pharmacological treatment can be implemented, because this is associated with reduction of cardiovascular risk, a modest blood pressure reduction, and it may facilitate the subsequent blood pressure lowering effect of antihypertensive drugs. And also, it may reduce the risk of developing hypertension throughout life. Well, the last point I want to make is that what I've just shown you, the recommendations for threshold of drug treatment by the guidelines of the European Society of Hypertension, is drastically different from the recommendation of the more recently published guidelines of the European Society of Cardiology. Now, to summarize the recommendations of these guidelines about drug threshold for treatment, well, if blood pressure is equal or above 190 millimeter mercury, drug treatment is recommended. This is indeed the same as the recommendation of the guidelines of the European Society of Hypertension. But in addition, these guidelines include in the treatment considerations the so-called elevated blood pressure values. That is, a systolic blood pressure of 130, 139 millimeter mercury, or a diastolic blood pressure of 70, 89 millimeter mercury. At these blood pressure values, drug treatment is recommended in high cardiovascular risk conditions. For example, patients with complicated diabetes, patients with familial hypercholesterolemia, patients with target organ damage, patients with advanced renal disease. And they recommend drug treatment also if the overall risk score is equal or above 10%. Not only this, but they also invite physicians to consider treatment if the total cardiovascular risk is below 10%, 5 to 9%, provided that they are what they call upward risk modifiers. And you can see a list, and some of them seems to me very vague. For example, socioeconomic disadvantages should convince doctors to use antihypertensive drugs in blood pressure values down to 120 millimeter mercury systolic, and if, of course, patients are, for example, poor. And the other point which is made is that these rules are valid also for individuals above 80 years of age. Just to simplify, if my patient has 122 millimeter mercury, an age of 82 years, and a risk of greater than 10%, and please remember that above 70 years of age, just because of age, virtually all patients have a risk above 10%. Well, then I should try to reduce blood pressure below the value of 122 millimeter mercury systolic. Now, is there evidence for this novelty about threshold blood pressure for treatment? My answer is no evidence whatsoever from individual trials. The only evidence comes from a meta-analysis of individual trials and individual patients in the trials, which have shown that there is a benefit of reducing blood pressure even when initial blood pressure is below 120 millimeter of mercury. So this means that virtually the entire population is a candidate to antihypertensive treatment. Now, about 2 years ago, a group of us wrote a paper which pointed to a number of problems in this meta-analysis. For example, 50% of the available trials was not included. Then what seems strange, but this is what happens, patients were already treated in many cases, and I think it's a paradox to use these data to see when treatment should be started when patients were already under treatment. But one important limitation, additional limitation, is that all trials were included, no matter whether they were blood pressure lowering trials. Look at how much blood pressure can reduce the risk, and comparison trial in which the purpose was to see the blood pressure independent protective effect of different drugs for a similar reduction in blood pressure. One other point I would like to make is that in the primary prevention group, cardiovascular risk was 31.9%. So many times greater than the levels of risk I mentioned before for these recommendations, that is more than 10% or 6 to 9%, and so on and so forth. So I think that based on evidence, the recommendations issued by the European Society of Hypertension are stronger than the recommendations of the European Society of Cardiology. Thank you very much for your kind attention.
Thank you, Dr. Mancia, for this informative lecture.